Good afternoon, everyone. My name is Shannon Kupka. I'm an improvement advisor working with the nursing home teams from Comagine Health. I'd like to welcome you to our half-hour Hot Topics series and our first session of the new year. Our 2020 series will explore CMS priority areas such as improving behavioral health and resident safety, reducing readmissions, opioid misuse and adverse drug events, infection prevention, antibiotic stewardship, and more. These webinars are designed to provide you great ideas on caring for your residents in a 30-minute time frame to accommodate your busy schedules. They are brought to you by the Comagine teams from Idaho, Nevada, New Mexico, Oregon, Utah, and Washington. A few housekeeping details before we start. Please let us know who's on the webinar today by entering your name and facility that you represent in chat, as well as the names of any folks joining you, so we have an accurate head count. Your cameras and microphones are muted. If you'd like to ask a question, please enter it in chat and we will facilitate a question and answer session at the end of the presentation. And please make sure that you're chatting to all panelists and attendees. We are really excited about our first presenter of 2020. Jennifer Pettis, MS, RN, CNE, WCC, is an Associate Director of the Long-Term Care Program for Nurses Improving Care for Health System Elders, NICH, at the New York University Myers College of Nursing. Established in 1992, NICH is the leading nurse-driven program designed to help hospitals and healthcare organizations improve the care of older adults. Her long-term care responsibilities include expanding academic offerings, engaging current facilities and organizations, and seeking new relationships to expand the overall program. She also ensures the clinical education content and materials are consistent with national standards and enhances current strategy and goals. Previously a nurse researcher at Apt Associates, Ms. Pettis participated in data collection, analysis, and reporting of healthcare payment, quality improvement, and quality reporting initiatives, and provided technical assistance and training through a variety of post-acute care projects. She has extensive clinical, managerial, consulting, and training experience, including as a consultant to the Division of Nursing Homes at the Centers for Medicare and Medicaid Services. While with the CMS, she provided the DNH with subject matter expertise regarding the resident assessment instrument and a variety of clinical and quality issues. Ms. Pettis currently serves as an adjunct faculty member for State University of New York Empire State College School of Nursing and provides subject matter expertise to CMS and the Chase Consulting Group team supporting their work with CMS under the MDS RAI Users Manual Support and Maintenance Contract. She also provides training for CMS's Skilled Nursing Facility Quality Reporting Program provider trainings. Ms. Pettis received her AAS in nursing from SUNY Adirondack and both her BS in healthcare management and MS in nursing education from SUNY Empire State College. I will now turn things over to Jennifer Pettis, and let's do a quick test audio with the group. Jen, can you say hello?
Yep, hello everyone, good afternoon.
And folks, would you mind just giving me a quick chat to tell me if you can hear Jen okay? Yes, okay, wonderful. Jen, you may get started.
Okay, welcome everyone. I've got a lot of information to share with you today on this topic that I'm very excited to share some insights with, and I'm hopeful to engage you all in some chat as we go through the program today. Our objectives appear on your slide right now, and we're going to talk first about the impact of adverse events in nursing homes, and then I'll share with you 3 types of adverse events I've identified by the Office of the Inspector General, or OIG. And then we'll look at a case study using the Centers for Medicare and Medicaid Services, or CMS Trigger Tool for adverse events. And I want to mention that you're going to get a glimpse of this trigger tool today, but then in our second session, part 2 of this program, which will be next month, we will work together to look at this tool a bit more and focus on how you can use it as part of your QAPI programs within your organizations. So I think it's useful to just set the stage with some headlines, and I like to share these headlines because adverse events don't only affect our residents or our patients and our healthcare organizations, they affect our staff and ourselves. And these are just a few of the headlines. The one that I want to point out first is in black on the right-hand side. It says nurse charged with homicide for a medication error. This happened in 2018, and it made the news when a nurse was at Vanderbilt University Hospital in Nashville, gave the wrong medication. It caused the patient's death late in 2017, and she was indicted and arrested for impaired adult abuse and reckless homicide. There's one that mentions the nurse's suicide highlights twin tragedies of medical errors. And this happened up in Seattle back in 2010 when a nurse, a long-time wonderful nurse, gave the wrong dose of a medication to a child who passed away. The error led to her dismissal, firing, and later her suicide at age 50. There's a study that suggests that medical errors are the third leading cause of death. And that 10% of all U.S. errors are due to medical error. And then there was a day-and-a-half trial down in Georgia where a jury awarded a woman $2.6 million. She went into a hospital in 2013 to have her finger examined. She fell from a wheelchair. She sustained a fracture, and she got $2.6 million in damages. And then in 2015, this was a headline, a popular blood thinner causing deaths and injuries in nursing homes. And the first line of that article was when they give the name of the person, arrived in the emergency room on October 13th, 2013. Bruises covered his frail body and blood oozed from his gums. And again, this is happening in the news, and it's scary. It's scary for our residents, and it's scary for the clinicians who care for these vulnerable individuals. So there's lots of definitions for adverse events out there, and I'm going to share just a few. And there's in the Institute of Medicine, now the National Academies of Science, Engineering, and Medicine, defined adverse events as an event that results in unintended harm to the patient by an act of commission or omission rather than the underlying disease or condition. When you compare that definition to the definition that I have here on your screen, which is CMS's definition, and that is that the adverse event is an untoward, undesirable, and usually unanticipated event that causes death, serious injury, harm, or the risk thereof. So I just want to draw your attention to the difference between the IOM definition, which says there has been unintended harm, versus CMS's definition, which does more closely align with the Veterans Administration definition that really talks about the risk thereof. So these are the near misses, and we're going to talk more about near misses as we go through today's program. So it's time for me to take a breath and ask you guys to chat and tell me about, when you think of adverse events, what comes to mind? So when you say, oh, we're going to prevent adverse events in our facility, think about what type of events come to mind. Elopements. Elopements always a hot topic. That's a good one. Falls with injury is one that's mentioned. I also want you to think about, in addition to the types of events that come to mind, someone says an event that could have been avoided. Think about the potential ramifications. So if you think about elopement or you think about fall with injury, how about those hot water incidents from those mixer valves that are notorious in nursing homes? How about infections that could have been prevented? Or pressure ulcers that were nosocomial ulcers that are injuries that occur, shouldn't have happened. What do you think about with those issues as ramifications of that? And again, go ahead and chat in your thoughts here for just a moment. Someone says lawsuits, things that could be prevented in lawsuits. Recently, in a town not too far from mine, there was a headline in the newspaper, loss of family faith. That's an excellent one. There was a headline in a newspaper where a resident had died. They had gotten caught in a side rail and passed away. And you can bet that that made the headline of the local news. So that leads to loss of family, our reputation impacts, staff impact. We just talked about the second victims of adverse events. Refusals, and someone says refusals and non-compliance, an increase in adverse events. So when things don't happen, residents have injuries, devastating injuries like a TBI or a brain bleed related to a fall. Once a facility local to me had a resident whose dresser or a bureau tripped over on them. And that resident, on the third time that it tipped over on them, did have a head injury that was a fatal injury. So med errors, lots of bad stuff, right, we think of. So we don't even only think about events, but we think about events that perhaps happen, as Debbie says, when we don't follow standards of care or best practices or care plans. And then we think about devastating potential ramifications of those. So let's look at some facts about adverse events and really how often these things happen. So the Office of the Inspector General, or the OIG, published a report in February of 2014, and in that report they estimate the incidence, national incidence of adverse events in skilled nursing stays. These are skilled nursing stays that began within a day of the beneficiary's discharge from the hospital. The individual had a length of stay in a skilled nursing facility of 35 days or less, and their stay ended in August of 2011. What they estimated is that 22% of Medicare beneficiaries experienced adverse events during their S&F stay. Another 11% experienced temporary harm events, which under the CMS definition would be an adverse event. And the physician reviewers who reviewed these cases determined that nearly 60%, 59%, were clearly or likely preventable. And preventable harm was most often due to substandard treatment, inadequate resident monitoring, failure or delay in treatment, and inadequate resident assessment and care planning. Over half of these residents who had an adverse event returned to the hospital, and that cost Medicare $208 million in that single month of August 2011, and equates to a fiscal year 2011 overall cost of hospital treatment for harm caused in SNFs at $2.8 billion. As a result, the OIG made several recommendations to CMS aimed at addressing adverse events, and including in those were goals that would help to increase nursing home safety, reducing resident harm. CMS began as a result a campaign around reducing adverse events, and they developed and tested an adverse event focus survey called the Focus Survey Medication Safety Systems. And that's the tool that I'm going to share with you today. I was lucky enough to be involved in that work in creating that survey and also in the campaign around adverse events. So hopefully I can share some useful information today. So CMS ended up working with the Agency for Healthcare Research and Quality, or AHRQ, with input from the OIG. They developed a list of potentially preventable nursing home adverse events that were cited in the report. And emphasis was placed on those that were determined to be preventable, high risk, and occur frequently. And they were related to three things: medication, resident care, and infection. And let's look at each of these just a bit. First, we have medication related, and there's a huge list of these, and you can see what they relate to. They relate to opiates and psychotropic medications, anti-diabetic medications, antithrombotic medications. So in both of the anti-diabetic and the antithrombotic, they had events related to too much or not enough. We have the constipation, ileus, or impaction related to opioid medications, electrolyte imbalances related to diuretics, drug toxicities related to everything from acetaminophen to antibiotics to valproic acid, levothyroxine, and everything in between, and altered cardiac output related to cardiac or blood pressure meds. There was this huge category related to resident care, and these were things like falls, other trauma, again, electrolyte imbalances, here not related to meds, but related to inadequate fluid maintenance. The thromboembolic events related to monitoring, so monitoring provision of care, labs, responding to those labs. Respiratory distress for residents who were dependent on either a tracheostomy or a ventilator. Exacerbations of pre-existing conditions related to inadequate or omitted care. And this is really where I think about that kind of cascade effect where you start with one little change in your resident, doesn't get picked up, another little change happens, another little change happens, and suddenly that resident's headed back to the hospital with this kind of trail of breadcrumbs that's leading to get them there. Feeding tube complications related to inadequate monitoring and provision of care, pressure ulcers or injuries, and the one that was mentioned first on today's chat, elopement. And there also were preventable adverse events related to infection. We had respiratory infections like pneumonia and flu, skin and wound infection like soft tissue or surgical site infections, UTIs including catheter-associated UTIs, and infectious diarrhea like C. diff or norovirus. So there is a national action plan to address adverse events. And in this national action plan, I'm certainly not going to share the whole thing with you. We just don't have time. I just want to mention these 3 high flyers. Most adverse events or adverse drug events that happened in hospitalized individuals are attributed to anticoagulants and opioids. And then a large number also are attributed to, believe it or not, oral diabetic agents. So it is diabetic agents in general, but the oral diabetic agents were called out as a problem. And they also recognize that there are groups of folks like pediatrics, older adults, individuals with lower socioeconomic status or low health literacy, and certain minority or ethnic groups that are more likely to experience adverse events. And among those is, as I mentioned, older adults. Even though they make up 35% of all inpatient stays, they are actually contribute to 53% of inpatient stays that are complicated by adverse drug events. So as part of that action plan for ADE prevention, there's a 4-pronged approach, and it starts with surveillance. So coordinating federal surveillance resources and data, so really looking for federal agencies to coordinate with each other to really focus at a population-based level. So really coordination and measuring and tracking ADAs. Adverse drug events, and then also prevention. So there are lots and lots of evidence-based tools out there, and so the action plan calls for folks to share those tools and get them in the hands of the providers. And then incentive oversight. We know that we are incentivized to provide quality of care. Oversight, our organizations like our state survey agencies and other organizations certainly provide oversight on this. And we also know that there are gaps in the research and understanding what goes into adverse events and how to prevent them. So there is a call to identify those gaps in research and then generate that research in order to ensure resident safety. So in one of the news briefs that CMS put out that is around, they have a series of QAPI news briefs, and one of them is around adverse drug events. And there is this story of Mr. Edwards or Mr. E. And, you know, I fear that this story happens all too frequently in nursing homes. So let's take a look. So Mr. E is a resident that Ann, a surveyor, met during a recent annual survey at a nursing home. On the first day of the survey, while chatting with Mr. E, Ann noticed that he had several bruises on his hands and forearms. He was alert and oriented and explained that he couldn't remember what caused the bruise, but that he'd been bruising more easily lately. He asked Ann if they could talk the next day because he wasn't feeling very well and he wanted to rest. The following day, the charge nurse told Ann that Mr. E had been transferred to the hospital. Upon review of his medical record, Ann found that Mr. E experienced profuse rectal bleeding in the middle of the night. The nurse's notes described Mr. E as being fearful that he was not going to recover, and he experienced a panic attack. He was admitted to the hospital with a GI bleed secondary to warfarin use. So upon further review of his medical record, Ann found that the warfarin was prescribed for Mr. E approximately 8 months prior to the surgery for newly diagnosed atrial fib. I'm sorry, prior to the survey for newly diagnosed atrial fib. At that time, the physician noted that the target international normalized ratio, or INR, for Mr. E should be 2 to 3. Initially, frequent blood tests to monitor the INR were conducted. Warfarin doses were consistently reviewed in response to his INR results, and changes often resulted, particularly early in the warfarin therapy. Upon notification of the INR, the physician routinely ordered the next lab. And identified issues related to the warfarin management around the time that Mr. E had a dental procedure, which occurred approximately 6 weeks prior to the survey. The physician stopped Mr. E's warfarin for 5 days before a dental surgery or dental procedure, and also discontinued the INR monitoring at that time. Following the dental procedure, the physician resumed Mr. E's warfarin for 5 days before the surgery, but he also ordered a course of erythromycin, a drug known to increase the effect of warfarin. However, the physician did not reorder the INR monitoring. Since the restart of his warfarin, approximately 5.5 weeks before the survey, Mr. E did not have his INR monitored. It was 9.2 at the time of his hospital admission. So I want to ask you guys again to chat. What in your policy or procedure, what is your stopgap that you have in your facility that this could never happen to Mr. E in your facility? Go ahead and tell us what ideas you have in your facilities that would prevent this. I'm not seeing any chat. I'm hoping that's because you're having a snack with your hands and not because you don't have any ways to prevent this. Any ideas out there? When I was in, there we go. Our warfarin responds, orders require a corresponding lab order. Absolutely. The INR, next INR is listed on their lab order. That is what we did in the facility in which I worked the longest time. I hate to say it, we started it because we had a problem one year, but we had our warfarins, you could not send a warfarin order through the supervisor's office without the corresponding INR date on it. Some folks do weekly audit. Pharmacy now won't send Coumadin. That's awesome. And staff are educated with the risks. Wonderful. So the use and the monitoring. Hopefully the staff would know that bruising on his arms was something we should be reporting and checking out. Great job. Flow sheet is checked every day by the manager. Wow. Daily Coumadin log to minimize the risk. Okay, you just had an issue. I mentioned to you before that there was a survey that was trialed, and I will tell you it's pretty easy to find Coumadin problems in nursing homes. So I know I'm running close on time, but I'm going to share with you the Adverse Drug Event Trigger Tool. And you guys have this tool. It is available. Oops, Shannon just sent it right there. And for you to download. This tool is available on the CMS website. It is a tool that was made to use during the adverse drug event surveys, the medication safety system surveys, focus surveys, and then this also was made available to surveyors. And you can see that it names an adverse drug event. It lists risk factors and triggers. So if I was reviewing a chart and I saw either a sign or symptom or a clinical intervention that's a trigger, then these surveyor probes actually are questions that I can ask if I'm a surveyor or if I'm using this as a QA tool to then go down through and check things in this facility's systems. So this is a great tool. We are going to look more closely at this in our next webinar. But using this tool, this could have helped us with Mr. Edwards. Several probes that are on the trigger tool could have helped us to ensure that there were intact, well-functioning systems to prevent ADEs. One would have been lab monitoring, and that you guys all, several of you mentioned, a system for routine monitoring. You've got a flow sheet, or you've got pharmacy that won't accept that order, new Coumadin order without a lab. Education, someone mentioned this, and a system of ensuring that caregivers and the resident and their family are educated on signs and symptoms of excessive bleeding, a result of that anticoagulant therapy that may have led to early detection of Mr. E's elevated INR. Or alerts, a system of ensuring prescribers and nursing staff are alerted when anticoagulants combine with drugs that increase the risk, that they would have known about that. So think about even if pharmacy had sent back an alert that said, hey, we just got this emicin order and he is already on Comagine. Should we get it sooner? Should we get another INR? As I said, in our next session, we'll look at this a bit more, and we'll discuss root cause analysis, one of my very favorite topics to discuss, and then we'll also look at evidence-based practice just a bit. So with that, I'm going to turn it back over to Shannon.
Okay, wonderful. Thank you, Jen. Great information. And we're going to have Jen for a part 2, so I'd like you to start thinking about some questions that you're going to put in chat. While you are doing so, I'd like to tell you a little bit more about our new Comagine Health initiative. We are embarking on a partnership to reimagine healthcare, working with providers across all care settings on issues like improving patient safety, looking at care transitions, increasing access to behavioral health, addressing opioid misuse, looking at admissions, readmissions, and emergency room visits. And providers who join the partnership will receive expert coaching and technical support, education and resources, and will have access to their performance measures via our new interactive data portal. This is offered to you at no cost, and joining is as easy as clicking on the link in chat, which I'll enter in a moment, to sign up, or putting your name into chat for one of our team leads to reach out with more information if you haven't yet had opportunity to sign up. So if you like these hot topics, if you like receiving the email prevention gems from your team leads and getting access to your performance reports, join us today. And so what we will do, oh, we got a thank you from Mariah saying she's liking this series quite a bit, is please take a moment and enter any questions that you have into chat.
And while you folks are entering questions, I just want to say thank you. Thanks to my colleagues at Comagine for inviting me to join them, and thank you guys for joining me on a Friday afternoon. I hear there's a big old football game this weekend, so hopefully you can make it on Monday after that game. I hope you're able to enjoy it and have some fun with family and friends. And I did include a couple of slides of references that will be made available to you, I believe, as well. A list of references, perhaps.
Yes, we're going to send them out in an email to everyone who attended today, so look for that. And I've posted I posted a link into chat for those of you who might not have had opportunity to join the partnership that will get you some more information. I'm going to give you probably about another 30 seconds or so to think about anything that you'd like to ask Jen while we have her this afternoon. And again, while we have a moment, I encourage you to check out all of our posted webinars that we have in our nursing home library in our Hot Topics. If you haven't been to a Hot Topics series yet, we have great presentations over the last couple of years focusing on antipsychotic use, working with people with behavioral health needs. So a lot of really good information in a concise format for you. All right, I'm going to give you a few more seconds to enter in any questions that you might have. Jen, I think you have either really bowled people over or just answered every question that they have. So.
Or talked too fast that they couldn't think fast enough to get them in there. This is great. I really appreciate the turnout. It's a great turnout and a really important topic, and I hope that you did find it useful, and I trust that you'll find part 2 useful as well.